Welcome to OncoPharma. I'm your host, John Bazar. I'm a professor of pharmacy practice here at ETSU's Bill Gatton College of Pharmacy, and this podcast is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. A couple quick updates before we get into maybe the recent FDA approvals. Daraxonrasib, the on-RAS inhibitor with really promising overall survival benefit, second-line metastatic pancreatic cancer, has been accepted now. FDA has accepted their new drug application, their NDA, which means now FDA is able to review the materials and hopefully grant approval for the product as soon as possible. Just, on a prior podcast, I talked about how it was kind of odd for FDA to come out with this compassionate use program so early. And I hypothesized maybe this is because it's a new drug company and they're learning how to submit to FDA. So I want to go through a timeline of a couple different things. So first, I'll go through this timeline for daraxonrasib. So on April 13th, now more than 3 months ago, the company put out their press release saying we have, quote, unprecedented survival in pancreatic cancer, which was ended up, being true. So that's 4/13. About 2 weeks later, on 4/28, they request FDA to allow compassionate use of their product. That is granted on 4/30. FDA grants that. 501 kind of goes into place. This is published May 31st of 2026. Okay, so the company does their press release. 2 weeks after that, compassionate use is requested and kind of granted. And then a month after that, we get the publication, which I'm pretty sure was simultaneous with ASCO, which would have been around that time, end of May, 1st of June. Fast forward about 8 weeks now, their NDA is ready to be submitted and FDA requests that. So this company is a new company. Is putting together all their data, generating interest, putting out press release. If you look at their stock price, goes up after their press release. Now it goes to the FDA. My guess is this company maybe gets sold or somebody buys rights to this with a higher stock price. But it's taking a little bit longer to get the FDA approval, which should get access to patients faster. There's another unanswered question, which is going to be commercial availability of this drug and the manufacturing capability to ramp up to make as much drug as the demand, I think, is going to be for this. Okay, as an analogy, as a comparison, all right? So enfortuamb, vedodin, and pembrolizumab in cisplatin-eligible patients with muscle-invasive bladder cancer was just FDA approved on the 10th of July, so about 2 weeks ago, okay? Now, that data was presented at ASCO GU March 2nd of this year. You go 4 months later, you get the FDA approval, and then about 2 weeks after that, we get the publication, which came out this week. So we're kind of waiting for that publication to see, is this as great as it looks to be. In this case, the FDA approval for this new combination came before the publication. Now, this is not an apples to oranges. It's like an apple to a steak comparison, because EV and Pembro are both already FDA approved, whereas daraxonrasib is not. There's already lots of that drug made. Manufacturing is already ramping up that, just as a comparison to that process. Now that we have the publication, EV Pembro in cisplatin-eligible patients with muscle-invasive bladder cancer does look as good as we thought from the presentation at ASCO GU and what we got from the FDA approval. They did change the protocol to allow for adjuvant nivolumab in patients. They had to have PD-L1 of more than 1% in Europe, which is the approval there. Only about 8% of people end up getting adjuvant nivolumab. Probably should have been more than that, but based on the time of when they changed the protocol and the number of patients in the cisplatin eligible arm who had a pathologic complete response, maybe it's not a whole lot more than 8%. That's not going to change your PCR rates, although if you got perioperative durvalumab, it would. So we still have this issue of not a great comparison with cisplatin gemcitabine. Would have loved to have seen dosed in MBAC or cisgem plus immune checkpoint inhibitor. There were really no red flags either in the publication. There's more toxicity in EV Pembro because you're on the drug longer. If you look at the subgroup for the event-free survival or disease-free survival, I think it's event-free survival. You don't see any red flags. In fact, the worse the patient's disease is, the more relative benefit of enfortuamb, vedodin, and pembro compared to cisgem. So those folks who had node-positive disease had a more impressive hazard ratio point estimate than those who had T4 without, T4 disease without nodal involvement versus those who had T2 disease, for example. So looks really promising. What's next now for this? It's something I kind of tell learners. If there is a major publication like there is for this publication, when it's out in like the New England Journal of Medicine, there's usually a nice editorial or commentary talking about it. We have that for this case, and in that you learn that there's the next step here is a study called EV209, which is phase 2, going to accrue about 240 patients. Looks to be a single-arm study, and the primary endpoint is bladder intact event-free survival at 2 years, which is a new endpoint that they made up. And essentially, they're going to get EV and pembro for 9 cycles, and at that point, if their cancer is not improved, then they're off study. They got to do some other treatment, probably cisplatin-based chemo, and then hopefully cystectomy. But if they've had some improvement in their bladder cancer, then they continue treatment, and basically they're going to try to get an accurate assessment of how long, what percentage of patients can be alive without their disease getting worse and having their bladder intact, because the bladder cancer surgery to remove that bladder is pretty morbid. You end up with like an ileal conduit, so you have urine going into your intestine, chance of intestinal matter going back into, not from your bladder to your intestine, but from your ureters into your intestines, chance of cystitis. You could have a stoma. They're just not great options there to remove your bladder. Okay. A lot of people, who listen to this pod, they're just, they're actively trying to learn oncology, whether you're new to the specialty, just trying to deepen your understanding of a particular disease state. To help, Kelly Carlstrom, founder of Kelly C. PharmD and the ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type, helping you organize key concepts like risk factors, symptoms, biomarkers, staging, and treatment. Download the Learning Oncology Companion using the link in the show notes. Okay. A couple quick hitter on an FDA approval. On the 14th of July, FDA approved selpercatinib. Well, it converted the approval for selpercatinib in a site-agnostic fashion for metastatic or advanced RET fusion solid tumors from an accelerated approval to a regular approval. So this is now a regular site-agnostic approval. There are also approvals specifically for non-small cell lung cancer and some thyroid cancers. Just as a quick kind of pearl, as I refreshed my memory on this drug, one thing that stands out to this, if you review the data in the PI, is if you look in the clinical pharmacology section, where they are testing the drug from an electrophysiology standpoint. Does it prolong the QT interval? This is in healthy patients. And in that section 12, they say that, we estimate the average increase in QTc at about 10 milliseconds, maybe up to 12. That would be the upper bound of a 90% confidence interval. Well, there's a box warning for QT prolongation where we see that in about 20% of people, the QTc interval increased by more than 60 milliseconds, and about 7% of QTc greater than 500. So looks to be a lot more QT prolongation in this drug when it's used in people with cancer than in healthy patients. A lot of reasons for that. Patients with cancer, advanced cancer, second-line treatment with their cancer, they're sicker, they're on more other medications that could prolong the QT interval, they have more electrolyte abnormalities that can contribute to QT prolongation. So a drug that does require ECG monitoring for that QT interval. Now, the last thing I have to talk about is a new drug, right? And we love talking about new drugs. This is Gedatolisib, like get out of here, Gedatolisib, which is approved in combination with fulvestrant, with or without palbociclib, in hormone receptor positive, HER2 negative metastatic breast cancer in the second-line setting. And all these patients with breast cancer were treated initially with an AI and a CDK4/6 inhibitor, and some of them were continuing on palbociclib in the study. That was the publication. This is Victoria, spelled with a K. If you're a breast cancer study, you have to name your study after a female's name. FDA says so. Now, these patients so they're getting fulvestrant, a third are getting palbociclib, a third are not getting palbociclib, and the other third are just getting fulvestrant, which is probably under treatment, let's be honest. Second line, metastatic breast cancer without PIK3CA mutations. And that's notable. Like, why do they say that? They just say this is they say that because Gedatolisib is a pan PIK3CA inhibitor. It inhibits the alpha, the beta, the delta, and the gamma isoforms. And so if you had, say, a mutation in this pathway, you go down the palbociclib, enfortuamb, capivasertib, that pathway. So this is a way you can do this in people that don't have PIK3CA mutation, which is, not a, this includes the mTOR pathway, AKT pathway. We've already blocked this pathway before in breast cancer with the Bolero study with exemestane plus everolimus, which people don't use anymore because it's pretty darn toxic and its benefit is somewhat limited. So this Gedatolisib, what is the brand name of this drug? Maybe it's easier to say. Probably not. Revtorpic. Gedatolisib. I don't know if I'm saying that right. Anyway, this is an IV drug, okay? It is given weekly for 3 weeks and 1 week off, so days 1, 8, 15, and then a week off. When you block the PIK3CA mTOR pathway, you get a lot of stomatitis. Similar to other drugs that work this way, you do have to give these folks a steroid mouthwash that's 4 times a day. If you have really bad stomatitis, you increase the frequency you use that mouthwash beyond 4 times a day. There's also warning precaution statements for rashes and hyperglycemia. We see the same thing with palbociclib. I think the fact that the drug does cause hyperglycemia in about half the patients is pretty common. They did not include anybody with type 1 or uncontrolled type 2 diabetes in the study, so we don't have a great idea of how worrisome that's going to be in those folks. There is nothing in the PI that says to start them on, prophylactic metformin like is often done with palbociclib. But what is notable with the hyperglycemia for this is this drug with administration has to be flushed with D5W. It is not compatible with sodium chloride or chloride-containing products. So you have a drug that you give 3 times a week that cause hyperglycemia, and you got to give them some dextrose at least not 3 times a week, but 3 times a month, okay? So that's one possible, limitation in the use of this, okay? The control arm here is just single agent fulvestrant. And, you can see the natural history of disease here in folks if you do fulvestrant is all these folks, the median progression-free survival is about 2 to 3 months. About half these patients, more than half, look like they're progressing at their first scan at that 2-month mark on fulvestrant. Now, many of those folks on fulvestrant probably have an ESR1 mutation and should be getting something like elacestrant or lumistrant and should be looking for that. Now, in the Victoria publication, they say, we didn't know about this when we designed the study, so we don't have those folks. So this control arm is below the standard of care. Very, very common in oncology. How good this drug is compared to, monitoring for ESR1 and putting these folks on these more potent drugs of fulvestrant, these younger cousins of fulvestrant. The second generation fulvestrants like elacestrant, we don't know, okay? So how effective this drug is, we don't know. We don't see any, the overall survival data are not fully mature yet, but you don't see any separation of the curves. You see big separation of the curves for progression-free survival if you care. The folks who got palbociclib, their hazard ratio is 0.24, very, very low. The folks who just got Gedatolisib and fulvestrant without the palbociclib, their hazard ratio is 0.33. Still pretty good, not quite as good. Of course, the company has an interest in both of those drugs, those arms looking good, so they're not designed to compare their 2 regimens together, just to this, inferior control arm of fulvestrant, because some of these folks have ESR1 mutations and should be on a drug better than fulvestrant. So, I don't think it's a drug that's going to be used a whole lot. For one, it's IV. There is a suggestion here. There's a hint that continued CDK4/6 inhibition has some benefit. There is, some rationale for this, in that if you're slowing the growth of, the goal here with metastatic cancer is you're not necessarily trying to get responses. You're trying to slow the progression. And it would be really interesting to see what the PFS2 data are for these 2 arms. The company is not, designed to compare these 2 arms, so I don't know that we'll get that. But that's maybe the more interesting thing about this. It is a new drug. It is an IV drug. Perhaps the most interesting thing about this is if you read the PI, I'm quoting here, the ability of Gedatolisib to induce CYP450 enzymes is unknown, given the results of the vitro studies. I think they mean in vitro. The vitro studies were inconclusive due to decreased viability of hepatocytes. One way to read that is that when you give this drug to hepatocytes in the lab, the liver cells die, which is something that has hurt other drugs targeting this pathway. Interestingly, there is not a boxed warning. There is not even a warning precautions about, liver toxicity. We do see that AST, ALT are increased in about a quarter of patients taking these drugs or taking this drug. The rates of grade 3 or 4 hepatotoxicity is about 3% or less. So doesn't seem to be that hepatotoxic in patients, but that's a little bit concerning. We don't have the full drug-drug interaction profile because they couldn't do the full studies to see if it induces hepatocytes. I guess if it's hurting hepatocytes in the lab, it's not going to induce them, but, what do I know? Okay, it also has, a warning precaution for embryo-fetal toxicity. It's metastatic breast cancer, so probably not a concern for the majority of patients who would be a candidate for this drug. But again, it's a PIK3CA inhibitor for patients that don't have mutations in the PIK3CA pathway. A little interesting. I'll also point out, I feel obligated, as a drug that inhibits all these isoforms, we have some proof of concept here. So in follicular lymphoma, the drug Gedatolisib, which was a delta isoform inhibitor for PIK3CA, that had some PFS benefit, was approved, then was withdrawn from the market because of inferior overall survival. Because the delta isoform is more prevalent in our lymphocytes, that's why it was approved for that, and it inhibits wild-type delta as well, as this one would, and we need those lymphocytes to be able to fight the cancers and potentially fight infection. So one thing that I think would be interesting to follow is, obviously the long-term data for this. Are there greater risk of infections, greater risk of secondary malignancies? Things we will not know until longer follow-up, but it is a newly approved drug, and that's kind of what I have this week. I'm just going to look real quick down here to see if they don't give a pronunciation. Revtorpic is how you're supposed to pronounce it. PIK, like PIK3CA. Revtorpic. All right, that's the brand name. Okay, that's what I have for you this week. Thank you so much for listening. You can follow me on X at FarmDeepNib and the podcast on other social media platforms at UncleFarmPod. And until I talk to you again, remember, doses matter.